Dear professionals, so this topic is a very important topic. Today we are going to cover the management of the diabetes. It includes two ways. One is non-pharmacological management and the second one is the pharmacological management. In the earlier class, we discussed about the non-pharmacological management of the diabetes that included your dietary approach, exercise programs, role of yoga, role of meditation, etc. So this class we are going to teach about the pharmacological management of the diabetes. This includes two ways of treatment. One is oral therapy, the second one is the parenteral therapy. So oral therapy, you have the different OHAs. They are the oral hypoglycemic agents ranging from your sulfonylureas, begonides, alpha glucosidase inhibitors, DP4 inhibitors, thiazolidinediones, SGLT2 inhibitors, and other immunomodulatory drugs like hydroxychloroquine, etc. So they include the different OHAs useful for most of our diabetic individuals, especially the type 2 diabetics, in about 80 to 90% of the cases. All the type 2 diabetes, they need the parenteral management that includes either injectable semaglutide or the insulin therapy at least in at some stage of the diabetes. For example, type 2 diabetes admitted in the cardiac ICU with acute myocardial infarction. So obviously your treatment of the choice for the management of the hyperglycemia is insulin. If you admitted in the medical ICU with septicemia, again your drug of choice in the management of your diabetes is insulin. Suppose he is admitted in the surgical unit, surgical ICU in the perioperative stage, posted for your cholecystectomy or appendectomy or some brain surgeries or some spinal surgeries. Again, even though the blood sugars are under good control with OHS, your drug of choice in the management of the perioperative period is obviously the insulin. So we should know much about the OHS, at the same time insulin also in the management of the type 2 diabetes. Of course, for the type 1 diabetes, you need insulin from the day 1 to the day of their death. But in type 2 diabetes, most of the people, they also require the insulin at some stage of their disease. So with this background, we will move on to the topic proper of the different OHAs available in our market. So in the next few hours, we would like to talk about define the treatment objectives in the diabetes. What is the basic understanding of the different oral anti-diabetic medications available in India? What are their merits and the demerits? What are their actions and what are their side effects also of the different OHAs available in our market? You should know most of the side effects rather than the main effects, because some people, they develop very catastrophic side effects with our OHAs unless you know them. So what are our treatment objectives? The simple objective is keep the blood sugars under euglycemic range. All our diabetic individuals are asymptomatic. Most of the people are asymptomatic. The most common symptom in diabetes is no symptom at all. But still, we give some medication just to prevent the long-term complications and also to give them a good quality of the life, to keep their blood sugars time in range, not to have the glycemic variability, and also we have to stress upon the comorbidities also along with the diabetes. So these are our treatment objectives. Correction of the acute metabolic abnormalities. Suppose if the person presents with the glucose toxicity, that means the fasting blood sugar more than 250, post-prandial blood sugar more than 350, HbA1c more than the 10 or the 11 or the 12, the person is in the glucose toxicity and then the urine ketone inverse will be the positive, and suppose you have to use your medications very judiciously, otherwise these people will end up with acute diabetic ketoacidosis, DKA. In elderly individuals, maybe HSS. And the same, on the other hand, if your insulin is of higher dosages, if the person skips the meals, or if he is on more prolonged physical activity, or the meal is delayed, so obviously presents with again acute metabolic abnormality, that is more common, is hypoglycemia. So acute metabolic abnormalities means hypoglycemia, DKA, HSS, rarely rarely lactic acidosis also. So these we have to correct these things, and we have to suspect these things in a person sitting in front of you, and definitely you can do good health. Yesterday I have seen one fellow who is working in SRM University in Chennai. He is a professor there, presented with the fasting blood sugar 350, postpone blood sugar 650, HbA1c 16%. So he came to me at about 1 p.m. last day, and he is about to catch the Sarkar Express at about 2:30 or 4, maybe 3, to go to his place of work, Chennai. So do you allow him to travel that much of the blood sugars? So he is in acute metabolic abnormality. Then he is in a rush. So doctor, please write some drugs. That too only OHS. I have to go to Chennai. I have to join the duty tomorrow morning, etc. Like that he is saying that. Then I added only one test. I am writing you only one test. It takes about 5 minutes, and that tells you whether you are supposed to admit or you will be treated as an outpatient. Then I asked urine ketone bodies. They are 4+. They are 4+. So lucky guy. Otherwise, what will happen? By evening or night, he will be in DKA with breathlessness. Okay, hyperventilation, dehydration. Already had the symptoms of polyuria, polyphagia, etc. And he lost nearly 5 kgs weight loss for the last 1 week. So see the educated fellows, the professors. So that is the scenario of the acute metabolic abnormalities in our society. Okay, then I asked him about, I told him about these risk factors, etc. and admitted and given the normal saline and given the intensive insulin therapy, and today morning he is very fine. Okay, so this is the very, very important. On the other hand, day before yesterday I have seen one fellow, a known diabetic, a present with unconsciousness state, with convulsions, the froth in the mouth, and the blood sugar is 20. So what is that? Hypoglycemia. So what is the treatment of the choice? Cheapest treatment of the choice? Okay, if he is conscious, allow him the sweet of his choice. Any kajas, any sweet. So that is the best time to take the sweet of his choice when he is in hypoglycemia. I asked him, what is your favorite sweets? He told 3 sweets. One is Potarekulu, the second one is Tapeswaram Kaja, and third one is Kotiya Kaja. And I asked them to get all the 3, 2 each. And he had taken all the 6 sweets. Then the blood sugar is 160 and 170. Fine. Because he is conscious. Suppose if the person is unconscious, so what to do? No sweets at all, no oral, only injectable, 25% extra, cost about 20 rupees, 30 rupees, etc. Immediately there will be a tremendous improvement, and he regained consciousness. Everything will be possible. So that is also possible. That is also acute metabolic abnormality. Last week I have seen one fellow from the old age home. Some Red Cross old age home is there, just behind APSP quarters. Female, aged about 82 years, presented with an unconscious state, with the blood sugars 800. Okay, and ketone bodies only 1+ or 2+. What is the situation? HSS, hyperglycemic, hyperosmolar state, severe dehydration. Dehydration is much more than your DKA. Unconsciousness is much more than your DKA. And DKA is in acute. It takes for only few days to become an DKA, but it takes few days to weeks to get HSS. That is hyperglycemic, hyperosmolar state. That is very common in elderly individuals. So that case is HSS. Which one is more mortality, high mortality? Is the DKA or HSS? HSS is more having the more mortality because of the severe dehydration because of the age group, very elderly, because of the other comorbidities. So that's how. So last week I have seen all the three acute metabolic abnormalities of the diabetes. So hypoglycemia, severe hypoglycemia, or mild hypoglycemia, moderate hypoglycemia, or DKA and HSS. They are all possible in our society. The thing is, you have to know which acute metabolic syndrome this is it, and immediately you can start the treatment, and the patient's recovery rate is almost 100%. Recovery rate is almost 100%. You get a lot of the professional satisfaction in treating these metabolic abnormalities. Long-term maintenance of the glycemic control to prevent the chronic complications. That is the very important. Follow-up is very important in all the diabetic individuals. Whatever the good treatment, whatever the best treatment you are supposed to start today, the patient has to continue for months, for years. Otherwise, short-term treatment of very good treatment is worse than the bad treatment of long-term disease. Suppose you have started one tablet, he is taking for 10 days or 15 days and stopped. No treatment for at all for another 3 months or the 4 months. On the other hand, another fellow is there, not attending to you at all, but he is taking the tablet, some tablet every day. So who is better? The second one is better, because something is better than nothing. So use any damn tablet, reduce the hyperglycemia. So in a long term, you will be all right. Suppose if the patient is educated, you want to give him good control, quality of the life, you want to control the long-term complications, then our lecture will help you. So which drug is useful, which drug is having side effects, etc. Identification and the treatment of the comorbidities. So in the last class also I discussed about ABCD of diabetes, or ABC of the diabetes. A stands for A1C, so I have to keep the blood sugars as close to the normal as possible. B stands for blood pressure, so you have to keep the blood pressure less than 130/80, and C stands for cholesterol, so you have to keep the total cholesterol or serum cholesterol less than 200, triglycerides around 150, HDL above 40 in the males, above 50 in the females. LDL, what is your LDL goal in diabetes? Even less than 35. If the person is post CABG or post PTCA, so your goal of LDL is very high risk individuals, very high risk individuals, 35. Okay, in moderate risk or high risk, your goal is 50. In general, 70. Diabetic without comorbidities, your goal is 70. So forget the 100, Baba, last bench. You should say at least good, at least good. So diabetes, your LDL, in general, a diabetic without any comorbidities, a simple diabetic without any comorbidities, your goal is 70, less than 70. Suppose a diabetic with some comorbidities, okay, a high risk individual, okay, he is a smoker, he is obese, a strong family history of the diabetes is there, he is also an hypertensive, the blood pressure is 140/90. So your goal is less than, not 30, 50. Suppose already had PTCA or had CABG, already admitted in the neuro ICU with an attack of CVA, then your goal is less than. Now, where are we? So, treatment of the ABC. A for stands for A1C, B stands for your BP, C stands for your cholesterol. Okay. Educate. So, I will tell you other parameters of lipid profile when we will deal with diabetes and dyslipidemia. Okay. So, you educating the patient regarding the disease and maintaining a high level of the motivation. This is the very important. I think the most important part of the diabetes is diabetic education. What is education? What is education? Good, medical education. What is diabetes? Diabetes and obesity. So you need, our people need education, medical education about the diabetes. This is a very important part. Why should you get that investigations of these things? Why should you get an ECG? Why should you get an X-ray? Why should you get an Doppler? Why should you get a urinary albumin creatinine ratio? Why should you get an ultrasound abdomen? Why should you get a complete urine examination about your urine microscopic? Or suppose if you had ordered the complete urine examination, what are the points you are supposed to see? So these are all the points you are supposed to see in the urine examination. Just seeing the urine sugar carries no marks, because one should not treat urine sugar. You should treat blood sugar. I have shown you the picture last time. The blood sugar, fasting blood sugar is 80, urine sugar is 2 plus. Post-prandial blood sugar is 120, urine sugar is 3 plus. Do you treat? What is that condition? Renal, glucose, urea. So glucose urea because of the renal. So that is the renal poor handling of the glucose. So showing you glucose urea. But whatever the blood glucose, 80, 90, 100. So we don't treat urine sugars. So getting the urine sugar in a diabetic is obsolete, not needed. But urine examination is needed. What are all the points I have told you? They are all important in a diabetic. So from tomorrow onwards, urine examination, you have to look after all these things. The management of type 2 diabetes has moved from being glucocentric to focusing on the cardiorenal risk factors such as hypertension, dyslipidemia, tobacco use, harmful use of alcohol, and overweight and obesity. See, earlier the management of the diabetes glucocentric. Glucocentric means we give importance to the blood sugars, fasting blood sugar, PP blood sugar, and treat accordingly. But nowadays we are not seeing not only the glucocentric but also individualized. We have to see the renal profiles. We have to respect the hepatic profile. We have to respect the lipid profile. We have to respect the HbA1c. We have to respect the LVH. We have to respect the ejection fraction. We have to respect the ankle brachial index. We have to respect the peripheral neuropathy symptoms in a person. We have to respect the retinal examination of the individual, whether it is a non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. And we have to respect the pregnancy in an young diabetic individuals. So these are all the very important. Now our management is, my aim right now is not only the glucocentric but also individualized. So all these things. Suppose if the person is a heavy smoker, so concentrate. Is the smoking is advisable for a diabetic? No, not at all. Any form of the smoking always causes vascular ill health, increases your endothelial dysfunction. It causes nitric oxide reduction, which is a potent vasodilator in the vessels. It causes more vasoconstriction. So definitely leads to the endothelial damage and more vascular events. Some people will have intermittent claudication in a chronic smokers. So that means your TAO. So they need peripheral vascular disease. They need the Doppler examination, etc. Otherwise, subject for the amputation also. This is very, very common. So all these things. So we have to ask all these things. Otherwise, you need not see the patient at all. Get the blood sugars done and then give the prescription. So why you have to examine the patient? So to record all these things. So that is the very, very important. Even you have to see the goiter also in a young females. Okay, so it could be a diabetes plus hypothyroidism. Some people will have diabetes and hyperthyroidism. Antibodies to the thyroid, antibodies to the pancreas, your TPO antibodies, etc. Hashimoto's thyroiditis, etc. So these are the very, very important. So don't think that diabetes is a single disease. Always think that diabetes is a cluster of many diseases. In fact, a metabolic syndrome. Okay, so diabetes means you have to see the blood pressure, you have to see the waist circumference, you have to see the lipids, so that all the four is ingredients of your metabolic syndrome. What is the name given to that metabolic syndrome? Metabolic syndrome is also called as Revans syndrome. Revans. Insulin resistance syndrome, Beer-Belly syndrome. This is about education. Okay, sorry. And glucocentric to the different things. So why do you need to treat the diabetes? Because diabetes is the leading cause of end-stage renal disease. So only two reasons for the end-stage renal disease in India. One is diabetes, the second one is hypertension. And the third one is combination of diabetes and hypertension. So very, very common. So what is the treatment of end-stage renal disease? Renal replacement therapy. Renal replacement therapy. Renal replacement therapy is of two ways. One is dialysis, the second one is transplantation. Dialysis of two types, hemodialysis and peritoneal dialysis. So end stage renal disease, the most important cause is diabetes. So the life will be very miserable. No salt, no pickles, no papad, no non-vegetarian, no coconut water. Okay, so all the restrictions are there, and all the keep the blood pressure as close to the normal as possible, but very, very difficult. CKD individuals, the blood pressure will be accelerated hypertension, 220 by 120, 260 by 140, like that. In whom? The people with CKD and end-stage renal disease. So what is the treatment of drug of choice in CKD as far as hypertension is concerned? Diabetic, CKD, the creatinine level is 6 or 7 or 8. So what is your drug of choice? Once the creatinine level is more than 3.5 or 4, you should not use AS or ARBs. Then what is the drug of choice? Good. Calcium channel blockers. They are the treatments. Suppose the creatinine level is normal, diabetic, hypertensive. What is the treatment of choice? Good, ARBs. These are the very, very important fundamental points. Okay. So for any diabetic, as long as the function is normal, kidney function is normal, the treatment of the choice is AS or ARBs. Once the creatinine level is more than 3.5 or 4 or 4.5 or 5, we have to stop the AS or ARBs, and we have to use calcium channel blockers, diuretics, alpha blockers, central acting drugs like arcomin, etc. Then why we should stop when the creatinine level is more than 3.5 or 4 AS or ARBs? For the fear of your potassium levels, hyperkalemia. So for the fear of the hyperkalemia, because the common side effect of AS or ARBs is hyperkalemia. Already the patient is in renal failure. Again the potassium levels will go up, and this hyperkalemia will attack the heart. Yes, arrhythmias and fibrillation and cardiac death. So that is the reason those fellows who are on AS or ARBs, please get the electrolytes, potassium, at least once in 3 months or once in 6 months or once in a year. Okay. When the potassium level is more, suppose you are using the telmisartan 80 mg or 40 mg, the potassium is 6. So what do you do? Do you continue ARB? No, very risky. So definitely we have to reduce the dose of that telmisartan, or you have to stop using telmisartan, and that is very, very important. So one of the major causes of the blindness. So the preventable blindness in India, two things. One is cataract, the second one is diabetic retinopathy. So all the diabetics should be screened for the retina. So from tomorrow onwards, if you are seeing any diabetic individual not seen by any ophthalmologist last 1 year, 2 years or 3 years, please ask them to consult a ophthalmologist. For what? For retina exam. You have to write a letter, otherwise they do only refractive error and then they send back. So you have to tell to the doctor that you have to educate this patient, educate the patient. So to ask the doctor to see the eyes in dilated eye, that is very important. So the retinopathy is of two types, non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Which one is more dangerous? Proliferative diabetic retinopathy. That is one of the important causes of the blindness in India. So once the fellow is in the proliferative diabetic retinopathy, so definitely we have to go for the laser therapy, etc. Otherwise, retinal detachment and complete vision loss. Type 1 diabetic. The girl got the type 1 diabetes at the age of 12 years or 13 years. Now she is 24 years or 25 years, married, want to conceive. So definitely the retina examination is very important. Suppose if the retina shows proliferative diabetic retinopathy, and we should not allow the pregnancy. It's a big contraindication. Otherwise, vision loss will be there. Suppose the non-proliferative diabetic retinopathy, continue the pregnancy. So that is also very important. Am I clear? So all these points are very, very important. Very, very important. Each point is very important. You please remember for your lifetime. See, the leading cause of the non-traumatic lower limb amputation. So whenever you see a fellow with the amputated leg on the road, only two reasons. One is traumatic amputation. The second one is diabetic foot amputation. So all the diabetic, if you see any diabetic food, so please give a lot of the priority to them. Incision and drainage, wide excision is always needed for all the diabetic individuals. That is the time to start insulin. Don't give OHS. Give insulin, give good antibiotics. Antibiotics covering both gram-positive, gram-negative and anaerobic organisms. If the person is not affordable, give ampicillin, gentamicin and metronidazole. If the patient can afford, you can give the Monosef, you can give the amikacin and you can give the metronidazole. Suppose the person is very rich, he can affordable, then you can give the Tazopact and amikacin and the metronidazole, or your meropenem or amikacin and metronidazole. So that means some antibiotics against gram-positive, some antibiotics against the gram-negative like aminoglycosides or Monosef or Tazopact or meropenem against the gram-positive, and then the anaerobic organisms for all the groups, it is the metronidazole. Okay, so don't be happy with only single antibiotic in a diabetic foot ulcers. So diabetic foot ulcers are polymicrobial. So polymicrobial means gram-positive, gram-negative and anaerobics also. So the two things will happen. Suppose if you don't control the sugars very effectively in a diabetic foot ulcer, then the infection will go up. Suppose if you don't control the infection properly, the sugars will go up. So on one hand infection, on the other hand blood sugars. When the blood sugars are very high, the infection will go up. When the infection is very high, the blood sugars also will go up. So what is our aim? To control both at a time, both simultaneously. So how you control the simultaneously? So for antibiotics, good coverage of the antibiotics. For the sugars, good amount of the insulin, not your 30/70 insulins, morning and the night, what you do regularly in your hospitals. You should give 24 hours covering of the blood sugars. How it is possible? With the basal bolus therapy, good basal bolus therapy. What you mean by the basal bolus therapy? Basal therapy means give one shot of the insulin at the bedtime, maybe your Insulatard or maybe your Glargine or a Detamir or the Deglutec. So that covers the basal hyperglycemia. Bolus means prandial insulin. So that means your regular insulin. Maybe your regular insulin or your Aspart, they are available, Novorapid or Eglucent, etc. Fiasp, rapid acting drugs, just before the breakfast, just before the lunch, just before the dinner. So they control the postprandial hyperglycemia. And nighttime bedtime insulin, your Glargine, so that controls your fasting blood sugars. So in that way, you can control the blood sugars very effectively with the 4 doses of the insulin, and with your 3 types of the antibiotics, you can control the infection very well. And then daily dressings, wide excision, incision and drainage, and everyday dressings. So your diabetic foot will be under good control in a span of maybe 3 to 5 days or the 7 days. It's very important. Don't think that diabetic foot is a small disease. Diabetic foot is a very big disease. So don't allow them to leave the hospital. So give them a good care with your daily dressings, antibiotics, control, etc. Then only you leave the patient. And the last one is cardiovascular risk equivalent. Cardiovascular risk equivalent. So you are dealing a case of the diabetes means a cardiovascular disease. So we should respect the heart function. You have to keep the heart beating till he or she achieved her 80th birthday or 90th birthday. So how it is possible? For giving a good cardioprotective drugs. So what are they? One is if they are overweight, reduce the body weight. If they are obese, reduce the body weight. If they are the smokers, cessation of the smoking. When the lipids are very high, treat them with your statins or fibrates or bempedoic acid, etc. If their blood pressure is very high, treat them with your ARBs or calcineurin blockers or diuretics or Concur, your beta blockers, etc. So you have to concentrate on the cardiovascular risk factors. They are the many cardiovascular risk factors. The 5 major risk factors are diabetes, hypertension, dyslipidemia, obesity, smoking. And then other things, maybe your apolipoprotein B, your lipoprotein little a, your ankle brachial index, carotid intima media thickness, your calcium score, your fatty liver, your hyperuricemia, your microalbuminuria, so your hyperhomocystinemia. So these are also other emerging risk factors for the vascular diseases. So how to treat all these things into consideration. So before saying that his heart is normal, But seeing the ECG, if the ECG is normal, doesn't mean that the heart is absolutely normal. Even in the myocardial infarction, the first ECG could be normal. So you have to observe the patient. If the person is complaining of the chest pain or the breathlessness or hypersweating or a diaphoresis and the sister taken an ECG that shows absolutely normal, so don't say that your heart is normal. Normal at this juncture. After 1 hour, again take an ECG, you can have a beautiful ST elevations, etc. So evolving myocardial infarction will occur. So high index of suspicion must be there in those individuals. In all uncontrolled diabetic individuals, so give respect to the breathlessness also. Most of our diabetic individuals, they may not have the chest pain. So what is the most common symptom of the myocardial infarction? Chest pain in a non-diabetic individual. In a diabetic individual, it is not the chest pain but breathlessness. So don't give the Decanron, don't give the Derifilin or inhalations, okay, or nebulizations in a diabetic individual with acute dyspnea. So that dyspnea could be a cardiac dyspnea. So this is very important. So if you are in a doubt, get an ECG done. Even if the ECG is normal, send the blood for troponin levels. And get the bedside echo also for any regional wall motion abnormalities. And then wait for about 2 hours or 3 hours or 4 hours. Again get an ECG. Meanwhile, the troponin levels will be negative and the second ECG is also the normal and the echo is the normal, also the normal. Then you can declare that at this juncture there are no features of myocardial infarction. Am I clear? So these are all the practical points. Okay. See the insulin therapy. See, when the insulin was entered into the market, 1900 to 1. Good, right answer. So 1921, one of the beautiful molecules in the world has arrived. Insulin. When it is entered into the market, next year only. 21 invention, 22 what? And then given to the patient, Thompson, in the New York hospital. He is in DKA, aged about 11 years or 12 years. His respiratory rate is 40 or 50. His blood pressure is maybe 60 by Curie. His heart rate is about 140 or 150. Ketone bodies are 4 plus. Dyspneic. He is about to die. They agreed to take this extract. Then given that insulin extract to that Thompson. So what happened? No ketone bodies. Good respiratory rate. Normal pulse rate. The BP is rising up. Reached to the normal. And gaining weight. Asymptomatic. And discharged from the hospital. It's a great news. Earlier, any fellow admitted with DKA definitely should go to forensic department. Forensic department. No forensic department. This fellow, he went to his home, his school. All the people surprised. How it happened? How you lived with the diagnosis of diabetic ketoacidosis? So then they said that this is because of our Banting and the best. Orthopedic surgeon and medical student. Banting. They invented the drug insulin and then changed the scenario of all the diabetic individuals. So I always tell my type 1 diabetic individuals, every day pray not only to your God of your choice but also to insulin molecule. So I give lot of respect to the insulin. So what happened without that insulin? Without insulin will go up and then he will die. He will die. So that is, see the picture here. See the picture here. So before the insulin therapy, after the insulin therapy, and then 7 years later, see what happened. 7 years later, possible with insulin therapy. Ade iduvarku aithe after 7 days, death body, death. 7 years later. And recently, not recently, maybe 3 years ago, 8 people were attended at Sydney for 1 day function. What is the occasion? 80 years of insulin therapy. How many years? 80 years of the insulin therapy. Okay, so they had a big party at Sydney, not in Florida, but in Sydney. See, imagine, is it possible? 80 years of diabetic life, type 1 diabetes? Yes. Is it possible or not? Possible, provided if you keep the blood sugars under control. If you keep the blood sugars under control, it is possible. Okay, 85 years, 90 years, all possible now. So that is the beauty of our insulin molecule in the market. So who is he? Jocelyn. Jocelyn is the father of modern diabetology. He is a physician. US, United States of America. He started an exclusive department of diabetes before insulin era. Before insulin era. So what is the treatment of diabetes before insulin? No drug. First drug is only insulin. See his vision, Jocelyn's vision. So he made most of our diabetic individuals under one department of diabetology. He told the importance of the diet. He told the importance of the exercise in type 2 diabetes. Okay, etc. and etc. And then slowly, after the starting of his department of the diabetology, insulin entered into the market. Then he used the insulin. He made a lot of the type 1 diabetes to live for the longer period. And after so many years, the first OHA entered into the market. When the first OHA entered into the market? After 30 years of the insulin therapy. So 30 years after your insulin therapy started OHS. See, the first 30 years, even though the person is a type 2 diabetes, what is the treatment of choice? Insulin. Okay, so then we have the lot of the drugs. See, he told Jocelyn, the aim of the treatment of the diabetes is to bring the blood glucose as close to the non-diabetic state as is possible. See the beautiful statement. Very simple. All the diabetics, you keep the blood sugars as close to the normal. Less than 100, below 100. Postprandial, below 140. HbA1c, 5.7. These are the normals. So see, so simple his statement. So keep all your diabetics. Fasting blood sugar less than 100, postprandial less than 140, HbA1c less than 5.7. They will be behaved as non-diabetics. They can live for longer period. So that is his motto. Very simple, but very, very difficult to reach those figures in a diabetic individual. Very easy to say, but very, very difficult to reach these figures. Not only for one day, you have to keep these figures for a longer period. Otherwise, what will happen to your HbA1c? Will go up. So today I skipped my breakfast. Now my blood sugar may be 90 or 100. Okay, and tomorrow I will take lot of the breakfast. Then my blood sugars will be maybe 140 or 160 or 170. Okay, so what will happen to my HbA1c? It will not be less than 5.7, maybe 5.9 or 9 or 10 or 6, etc. Suppose if I am not non-diabetic. So if you are diabetic, so definitely more than 6.57. So his statement is keep the blood sugars as close as possible, not for 1 day or 2 days, for a prolonged period. It's very, very difficult, but that should be our motto. So your motivation should reach to your patients to keep the blood sugars as close to the normal as possible to avoid the long-term complications. So can tight control of the blood glucose prevent the diabetes complications? Tight control, that means you are reaching to the normal levels. Good or bad? Good. So there are the different landmark trials are there. Your DCCT trial, the trial on the type 1 diabetes, your UKPDS trial, the trial on the type 2 diabetes. See the tight control of the diabetes, the DCCT results. Lower the HbA1c, the less the chance of developing the microvascular complications. For just 1% HbA1c reduction, you will find lot of the benefits in all the complications of the diabetes. Your retinopathy, nephropathy, neuropathy, all will reduce to the remarkable levels once you keep the blood sugar. See the HbA1c levels here, 10, 11, 12. So what will happen to your complications? Will go up, will go up. So lot of our, what is the average HbA1c in our Indian population? The average HbA1c, real world. Good, more than the 9. Good, 9.7, 9.6, 9.4, it depends on the persons. But the average HbA1c in Indian population is around 9.5. Is it normal or abnormal? So that is the very important. So the more the HbA1c, the more the blood sugars, the more the complications. So it's very easy to say that you have to keep these, but in the real world, even among our doctors, lot of my doctor patients, their HbA1c is not 6.5 or the 7. Most of their HbA1c is beyond 8, 8.5, 9, etc. and etc. because of the several reasons. So this is the very, very important. So all your diabetics should reach the figure 6.57. Otherwise, these people will go to the super specialists. See the benefits of the tight glycemic control in the type 2 diabetes. Just 0.9%. Say remember 1%. 1% reduction. Any diabetes related endpoint, 12% reduction. Any microvascular endpoints, 25% reduction. Myocardial infarction, 16%. Retinopathy, 21%. Albuminuria, 33%. Any difference you are seeing here in seeing the reduction of the complications? See the microvascular complications here, they are reducing. And also myocardial infarction is also reducing. But which complications are higher reduction? Microvascular complications. So what is the point here? Why the macrovascular complications are not reducing to that extent? Why not myocardial infarction 16% to 31% or 40%? Because macrovascular diseases, you have the other risk factors are also there. What are they? I told you the 5 macrovascular risk factors. Diabetes, smoking, hypertension, obesity, dyslipidemia, etc. etc. Diabetes is responsible for your myocardial infarction, 20%. Your hypertension is responsible for 20%. Your dyslipidemia is responsible for 20%. Your smoking responsible 20%. ఓకే పోనీ అందరికీ ఓ 15 వేసుకున్నాం అనుకో 5ంటికి ఓ 75, మిగతా 25% మేబీ స్ట్రాంగ్ ఫ్యామిలీ హిస్టరీ ఆర్ హైపర్ హోమోసిస్టమీ ఎట్సెట్రా ఎట్సెట్రా ఎట్సెట్రా. So to control the macrovascular complications like myocardial infarction, you should be very aggressive in dealing with the other comorbidities also. But the microvascular complications are directly proportional to your hyperglycemia. You got the point? So that is the reason. So while dealing a case of the diabetes, not only the microvascular complications reduction, you should also aim for the macrovascular complications like myocardial infarction reduction also. For that, you should pay a little more attention not only to the diabetes but also to the comorbidities. So you should not behave like a pure diabetologist, but you should also behave like a lipidologist, hypertensionologist, okay, bariatric physician. Who is lipidologist? Lipid specialist. Who is hypertensionologist? Hypertension specialist. Who is diabetologist? Diabetes specialist. You are all going to be the diabetologist. That is not sufficient. You should also behave like lipidologist. This is very important. See, every point is very important. Whatever I say, any point, that is very, very important for your clinical practice. Okay? So you should concentrate not only on the diabetes management, but also those things, then only you can control the myocardial infarction rate. Now tell me the answer. Most common cause of death in diabetes. Good, myocardial infarction. So now tell me, you should also behave like a lipidologist or not? Yes. Hypertensionologist or not? Yes. Because to make them to live for the longer period. So our people of diabetes should live for a longer period. The most common cause of death is myocardial infarction. You have to avoid the myocardial infarction. Not only the diabetes management, but also these things. What is this legacy? Memory. What is this legacy? Memory. Metabolic memory. Metabolic imprinting. or legacy effect. Metabolic memory means in the early days of the diabetic life, you have to control the blood sugars very aggressively. If you control the blood sugars in the early days of the diabetic life, they will not have the long-term complications. Suppose if you don't treat the diabetes very aggressively in the initial days, their long-term complications will be very high. So if you control the blood sugars very effectively in the initial days, so their long-term complications will be very poor. If you neglect the diabetes in the initial days, even though your control is good, afterwards they are going to get the long-term complications. So from tomorrow onwards, if you see a new diabetic, so what should you do? Good. So then that is a legacy effect. So these are the targets. Okay. So the fasting blood sugar, what is your target? Fasting blood sugar? That is the right answer. So this slide is not a good slide. So you want to become a diabetic or non-diabetic? So make him a non-diabetic. Non-diabetic means fasting should be less than 100. Postprandial should be less than 140. HbA1c should be less than, good, 6.5 less than, but around say 5.7. That is the best way. But it's not possible for all the population. So then you can extend in that way. So the targets need to be individualized. Okay, I stop here.